Well, good morning, everybody. My name is Jens Chapman, and we're still in COVID protective gear. It's a distinct pleasure to be welcoming you here today to SSF. Today is Wednesday, October 20th, pre-Halloween time, and here in Seattle it's raining. Today we have a great speaker here, Dr. Mark Moore. He's an MBA and a Ph.D. researcher. I'll introduce him in greater detail later. We're beholden to LifeNet, which has a injectable form of allograft with a ratchet gun. It's of particular interest to me because we've worked on this unsuccess in my time at UW, and to see this happening now is a big deal. As always, we will start with some basic cases that are very highly amenable towards the question of anterior column reconstruction. As you can see from this model here, we do have an interest in a controlled delivery of osteogenic material. And this is always kind of a little cumbersome and difficult right now. So I'm interested to hear Dr. Moore's thoughts on this. We'll ask him some critical questions also during his presentation, and we'll bring a microphone to you, Dr. Moore. Maybe I can ask you to sit further up front, one of those microphones. I know you're not a clinician, but I'll ask you some basic science questions at some point in time. So you can just have a seat over there if that's okay. Before I go into great detail, last night we had a great motion preservation feature. We do that roughly quarterly together with our colleagues from TVI and a number of centers around the country. And we had a great resonance of people. This serves as a lead-in for me to point out that this weekend, Friday evening and Saturday, we have a True Thought Leaders congregation on annual advances of motion preservation. This is again Friday evening and Saturday all day. And again, if you're remote, just zoom in and see thought leaders demonstrate surgeries in our cadaver lab at SSF. And we'll have debates, case presentations, and obviously true leaders in this field present. Ben, how are we doing back there? Are you okay? So here's the advancement slide for this. And again, Friday night, just go into our SSF TV website. We have, I think, 4 or 5 cases selected, and I'm going to just tee that up. And first speaker with 2 cases will be Dr. Nathan Pratt. He'll introduce himself further, where he's from. And Dr. Pratt, thanks for preparing these cases.
Yes. Good morning. I'm Nathan Pratt. Trained at University of Maryland Neurosurgery program, here for 1 year complex spine fellowship. I have AV assistance. I think it's up. Are we good? Okay. Oh, we're waiting for it to load there. I will have a couple of clinical cases today where one of them where biologic might have been helpful if some of this technology had been around at the time for us. This first case, PH is a 71-year-old female who presented with low back pain, leg pain after a fall. She had progressive bilateral lower extremity weakness, difficulty ambulating, past medical history, osteoporosis, pulmonary dysfunction, asthma, so on chronic steroids off and on, a number of issues that are going to affect her bone health. No prior spinal surgery. She had an otherwise negative or unremarkable history, at least. She has decreased sensation bilaterally. This patient's being seen in clinic. Decreased sensation bilaterally in her lower extremities. Strength was 4s in her bilateral knee flexors, dorsiflexors, EHL. Otherwise, she had full strength, and reflexes are minimally reduced. So her standing scoliosis x-rays are the best example of what's going on. She's got multiple compression fractures in a scoliotic curve, significant coronal and sagittal plane deformities. I apologize. I was trying to call you. The patient was initially managed conservatively at another facility. She had increased back pain, worsening leg weakness, and was then planned for a lateral followed by a posterior decompression infusion. She did well immediately post-op, had some improvement in her back pain and in her lower extremity weakness and numbness. Here's her construct. You can see her lateral interbody cages and her, as well as her, you can't see me, T-lift down at the bottom, had a solid construct, was doing relatively well initially after surgery. Unfortunately,
Okay, so
because
can I interrupt you for a
Oh, yeah.
second? So I know Dr. Moore is a PhD, but if you go back to the initial films where she came to us with this severely collapsed spine, do you have a close-up of any of these or a CT of these collapsed vertebrae?
I don't have that in here. I apologize.
So assume that there are, how do we call it when vertebral bodies are completely collapsed?
Vertebral plana. These she had at L2 and 3 had vertebral plana.
So this is an extreme case of a secondary deformity, a kyphos, scoliosis. And what underlying condition did this patient have that led to this complete collapse of several of her spine?
Osteoporosis.
Severe osteoporosis.
Yeah.
Do you remember the T-score or anything like that?
I think her T-score was less than -3, if I remember correctly. It was her initial T-score was very low.
Yeah, it was severely diminished. I forgot what the number was also.
It was less than 3.
And this is a normal citizen, right?
Yeah, she was otherwise a relatively normal person. She was not someone who was homeless or IBD or anything. Her big problem, and she didn't even have a significant family history of osteoporosis or anything like that. Her asthma led to chronic steroid use, so secondarily developed this as a result of that. That was really probably the primary issue for her. Weight didn't help her, but her weight should have decreased her risk of osteoporosis, not increased it.
So Dr. Moore, the question to you, I know you're not a clinician, you're a PhD, but the substance that you have, do you mind handing me this gun again? The substance that you have, is this something that you could inject into very osteopenic, osteoporotic vertebrae that have a gap in them, like a hole? Could you inject this with a cavity creation device also so that you can actually fill bone with a biologic substance?
Yes. Yes.
Can you speak close to the microphone? Put your mouth close to the microphone. I'm not sure this is on.
All right, thank you. The PhD didn't help me turn the microphone on. So yeah, we can, that particular material is it's a cellular bone matrix that comes preloaded in a cannula, and that can be injected in that tight space. What we find generally in cases like this is, and I'll explain it more in my talk, is clinicians tend to match the healing properties of the implant to the clinical complexity. In other words, if there's a very simple case, they may use a simple allograft chip, for example. But if there's cases where there's a feeling of needing more biology in there, then something like this, it would be an allograft with viable bone cells injected into that site would seem to make sense. And it certainly could be.
Dr. Schonert, I know you're on the panelist link. I don't know whether you can unmute yourself. I know you're getting ready to start in the operating rooms. If you can, yeah, here you are. And if you have a video also, it would be great to see a face. Otherwise, we'll take your voice and thoughts only. So unrecognized osteoporosis, and then lack or significant delayed clinical intervention in patients who start developing osteoporotic fractures is an ongoing major problem. Briefly outlining, what can we do to kind of stem this tide and avoid these major surgical reconstructions in patients with these severe problems?
Yes, Jens, thank you. This patient typified.
I can't hear you right now. I see your microphone is working. So I'll ask Ben to help us get you live.
I'll keep speaking in hopes that it'll eventually.
Still don't hear you.
Keep speaking. I'm still speaking. I'm off mute.
And I can't hear Dr. Schonert for some reason. I see his microphone is working.
Yep. Yep. I'm still speaking in the event that that's
now
helpful.
I can hear you. Thank you.
Okay, good. So the case typifies the silent epidemic, or as some of us call it, the silver tsunami that is going to arrive with our generation. The patient has steroid-dependent osteoporosis, has a very severe T-score. That's going to make a huge challenge for the surgeon, and there isn't time to intervene before surgery to bolster the bone, because the neurologic deficit compels you to treat immediately. But those of us who are focused in osteoporosis are going to try to identify these people before this catastrophe happens. If you do identify it after it happens, prompt treatment is very important, because delayed treatment only results in a tripling of costs.
This is very important. Now you've done and this deserves amazing recognition. We appreciate your collaboration always. As a private practitioner, you've created a registry that is remarkable and that also deals with osteoporotic fractures. In your registry work, when we look at levels of fractures, is there one region, like in this patient, a thoracolumbar collapse occurred, that is more at risk than others? Specifically, is L4 as bad as T12, L1? Is that as bad as T8, et cetera?
Yes, exactly correct. The preponderant fracture levels are in the lower thoracic and upper lumbar spine at the thoracolumbar junction, where the biomechanics of the spine change dramatically, but also the lumbosacral spine suffers because sacral insufficiency fractures can be compounded by lower lumbar fractures, and you have difficulty in stabilizing, especially in patients with a -3 T-score. This is going to be hugely challenging.
So one other quick question. So you've published on kyphoplasties and timely vertebroplasties actually having a great patient care and socioeconomic benefit. Can you see kind of an early injection of a bone matrix into a osteoporotic vertebra to be a potential benefit? And I'm not even sure what the biomechanics of this would be.
Short answer to that is yes. Long answer to that is hell yes. When we can identify these patients either on clinical characteristics, which the registry is particularly good at distilling, or using the available free data that comes off of these registry and 23andMe data sets, we're going to be able to identify women with characteristics that are highly probable to result in this catastrophe and intervene before it occurs. We'll need more data, more registry input. Presently, we're launching registry in the EU and in the UK so that we can start getting the numbers that we have in our registry is 1,100, but we need that at 11,000, 110,000 before we can develop these predictive capabilities. But this case typifies a woman who was clinically asymptomatic and functioning in society and now needs major reconstructive surgery. Thank you, Jan.
I'm going to ask, stay online, Neil. I'm going to ask Dr. Amir Abdul-Jabbar in a second to comment on our case also. Can you go forward again? Yeah. We did a pretty extreme surgery there, Neil. This is kind of shocking. We can't see the PowerPoint right now, Ben, in our screens, but if you can go back forward to the initial post-op.
This is the initial post-op.
Yeah, so we can't see it on our screen. Ben, if you can flash that up. So we did a pretty shocking surgery, high up and low down. Is this, I mean, there's a lot of hardware in there. Is this justifiable, Neil? Would you have done something less invasive?
If that question—
Can you hear me okay?
Yeah, here we go.
I'll start with Neil first and then go to you, Amir.
So the first thing to recognize is that you're put in a prejudiced position, and it's a difficult prejudice. The patient has profound bone deficiency, and if you go short, your probability of having to do additional surgery to compensate for the complications that'll occur junctionally is really high. The better thing is to get this thing in balance as quickly as possible, and then correct the fundamental problem that put you into this corner. Getting the bone densified so the implants have a chance to survive.
So Amir, since Dr. Oskourian and I did this in collaboration with one another, I'm going to put you on the spot. Do you think this is excessive? Could we have done a more limited surgery? Again, profoundly bad T-scores, an actually very healthy nurse, very fit, taking steroids, as Dr. Pratt has pointed out. Is this a shockingly too big a surgery? Could we have gotten away with less?
You know, I think you never know if it's too big or too small until you wait and see. You know, it's possible that you could have done slightly less, but doing more, I think, is always an appropriate option when someone has very poor bone quality. If you try to do short segment, you know, as Neil just mentioned, that's going to be a very high likelihood that they're going to need a revision. So, possibly too much, but, I think doing too much or too little is both a problem. And, I would rather err on the side of doing too much.
Thanks for that support. So we did, in recognition of the high degree of biomechanical forces that this extremely active woman will put upon her spine, we put cages in at literally every level, right, Nathan?
Yes.
So now tell us what happened.
So, and I apologize for not having it on here. Correction of 60 degrees. She had about 10 degrees of lumbar kyphosis preoperatively and a pelvic incidence of 50 degrees. She now has 45 degrees of lumbar lordosis. Her sagittal balance is back to normal. She had almost 15 centimeters positive sagittal balance preoperatively, and obviously her coronal balance is restored. I apologize for those numbers not being up there. So the patient, unfortunately, because of her body habitus, steroids and things like that, developed a seroma, had delayed wound healing with eventually a postoperative infection that required a wound revision with Dr. Gottlieb and our plastic surgeon. Approximately 6 months from the index surgery, patient presented again with a wound dehiscence. This is after already having had a wound revision from a posterior incision. She did not have an infection, was taken back to the operating room and had a complex revision once again. Then 2 weeks later, she had another dehiscence through the skin. The wound was then again closed. This time she did have appropriate wound healing and had improvement in her overall function. 9 months after this, patient reports again worsening severe low back pain. She had an uneventful course after that. Limited physical activity as a result, unable to really ambulate independently at this point. She denies any new focal neurologic deficit. She doesn't have any focal weakness, but she had persistent numbness, and some of that persistent weakness that she had had before surgery hadn't gone away yet. New standing scoliosis X-ray obtained, indicating pseudoarthrosis above the the L3-4 lateral inner body cage.
So this is a case that Dr. Squin, my neurosurgical partner, and I did together. I thought we did a nice job with an anterior column reconstruction. You put in beautiful X-lifts. What happened here, Rod? Why did this break? We put cages in, we put bone graft in, you put beautiful X-lift spacers in.
Mm-hmm.
Did we, is there a CT, Nathan?
I don't have the CT.
Oh, okay.
There is a
I
CT.
clearly
There is CT.
it didn't heal.
It didn't fuse.
Yeah.
Yeah. That's what happened.
That's the reason for
It did not fuse.
Did one rod break first and then the other?
We don't know that.
Okay.
We just have. This was the first time we saw it. This is the first rod fracture we saw. She didn't see us for 9 months and then came back saying, "Hey, my back pain got a lot worse."
So if you look carefully, she's starting to erode the vertebra. I forgot which level it was. I think it was L3 or L2. Yeah, L3.
Oh, it's L2 actually, because
L2 is starting to erode from that peak cage. So,
yes.
Neil, assume that we put in a little bit of off-label bone morphogenic protein. Did we use the wrong biomaterial? This is a very thin lady, so should we have used 4 rods, although the hardware prominence would be a significant issue. She already had soft tissue problems. She did not have a deep infection, fortunately. These were superficial erosions. What could we have done better to try to get better anterior column healing?
I was wondering if anyone was mentioning bone augmentation from the osteoporosis perspective of getting her on an anabolic and trying to reverse the fundamental cause, because it appears to me that the fundamental cause is still an active problem for her. And at a -3, it's going to take a while to get out of that deficit. Is she on Evenity or one of the anabolics?
At the time, she was on teriparatide, and it was the usual fight. This is a working nurse. She has a good, quote, good insurance. And yet again, we sent her to our excellent mineral metabolism center with Dr. Chris Schuhard, who's very engaged, very vocal in support of getting these medications approved, which are expensive in the short run for insurance companies, but in the big picture, save money. And we had that usual problem. So this is my next question to you is how long before do you want to prep a patient before they kind of get moving? And does it make sense to start the medication even 2 weeks before surgery? Again, this is a whole day surgery. This is not a little undertaking. There's a big investment on the part of the centers. So how long before does it make sense to start an anabolic bone augmentation medication?
We're blessed because one of our colleagues, Paul Anderson, is heading up the AOA's Own the Bone program, which is specifically looking into this. And to incorporate into the registry, the next step of pharma use is the reason I'm up this morning writing that grant. We want, in my practice where I don't have these massive deformities, I ask patients for a 3-month delay so that I can begin to optimize. Optimization of bone with an anabolic takes a minimum of 6 and really more realistically 18 months. And you cannot delay this operation for that time frame. So the question of, do we try a quadruple rod at the thoracolumbar junction? That's a legitimate question to ask, but we had already had the discussion of whether this is overkill or not, and it's clear it is not overkill, it's underkill. The biology is beating up on the biomechanics, and the biomechanics lost in this battle. It'll take longer to reconstitute sufficient bone in this woman biologically, so you still are in the midst of the battle that you were in on the day of her first surgery.
Great. Okay, Nathan, let's carry on. So we have a resolution here.
Taken back to the OR for a T2 to pelvic fusion with quad rod construct. She did recover very well from this, and I think this is the final one for her. Yeah, this was her follow-up x-ray. She had improvement in her strength and her numbness. You can see we restored her sagittal balance, and the patient is doing very well at this time. So
we just saw her in clinic, actually. I think she's 2 years out now.
Yep.
Something like that. She's, despite the long fusion construct, amazingly functional. Nathan, what did you see? How did we reconstruct the anterior column with that big deficiency?
the initial surgery?
No, now in this revision surgery.
Different?
What did we put into the anterior column to re-augment it? We didn't just do posterior hardware. We obviously put posterior hardware in.
Hey, Jens, I just have a question.
Yeah.
Why did you guys
Go back
remove
lateral.
the screws in between in the hook?
There was no screw purchase in there. When she had collapsed, basically the
They were
screws had loosened.
plain.
Really? Wow.
They were
Yeah.
planar.
Yeah.
So those were.
There's
That's
not a
shocking.
sensible bone in there anymore. I think you actually came in on that case. And I want to recognize, and we have a question from Dr. Sousley on FOTUS. Good morning to you about soft tissues. But we basically, as I remember, we actually fished that P cage out and we put in a new larger P cage.
Oh, yeah.
And we stuffed it full with bone graft. Again, having a delivery mechanism, if it's halfway affordable, that allows us to put larger quantities of bone graft and viable bone matrix into an anterior column in difficult to reach areas would be a clinician's dream. Currently, we use big pickups. And again, I failed to get something like this into production 2 decades ago. So just wanted to show you that, Dr. Moore, this is a clinician need, and getting a large amount of viable bone into the front would be a great desire. Now, FOTUS asked us a question. We're privileged to have Dr. Gottlieb. You have to get a microphone for yourself, though, to have a wonderful plastic surgeon who helps us in these complex cases. Dr. Suzanne asked the question of, do incisional vacs help? This woman is very thin. She is one of those high exercise people who does not have body mass, has a great FiO2, but not a lot of muscle mass. Does it help to put incisional vacs on for the critical first 72 hours or period X?
Question to me?
Question to Dr. Gottlieb, plastic surgeon. Yes.
The one.
A microphone's
Excuse
not
me.
on. Can you make sure your microphone works before you speak?
Hello? Hear
Yes.
me? Can you hear me?
Yes, you have to come closer.
The one proven study early, probably 10 or 15 years ago, was on chest incisions after coronary artery bypass, particularly when the internal mammary arteries are used for the bypass, decreasing blood supply to the mid-sternal area. And those clearly showed lower incidence of sternal osteomyelitis when external wound vacs are used. I'm not sure how many other studies have been done that prove that, but the mechanism of these, initially the guys at Bowman Gray who first conceived of the idea, apparently was a plastic surgeon fixing a lot of bed sores. And he asked his lab, can't you make something that'll suck these wounds closed? And the mechanism wasn't clear for a long time, but part of the mechanism is the negative pressure increases capillary blood flow to the wound edges, which are healing. And there's good reason from the cardiac surgery model to think that any wound that is at high risk to have wound healing problems will have a better chance of normal wound healing with a period of negative pressure.
So at Harborview, and Dr. Gottlieb was at Harborview also with me years ago. We had problems with our sacral fractures. We became very well known for having changed how fractures in the sacrum are cared for. We had wound healing problems. We published on that. So this is not a great disclosure or surprise. And we've never published that, but we decreased the amount of wound breakdowns empirically dramatically by putting incisional vacs on and just avoiding any fecal contamination, trying to get patients on their bellies to get them off their sweat trough posteriorly. So empirically, yes. Nathan has another case. Let's proceed. Thank you. So learning points here, early recognition of osteoporosis and intervention before we have to do dramatic surgeries. Despite this very major surgery, good bone healing and the anterior column is critical, still a little bit wanting. This patient had a terrific outcome in all subjective things. She can actually put her hand, you saw her with me, I think, she can put her hand on the floor. She's stretched her hips so well and crazy. Works out and is very happy. She actually works again.
She looks great. One more case here, kind of a different take, one that did not require anterior column reconstruction and or violation of the anterior column.
You gave it away.
Oh, I'm so sorry. I didn't mean to give it away. I thought you wanted me to mention it.
Give it away, give it away.
All right, 53-year-old man who presented with acutely worsening numbness in the right greater than lower extremity. He's got new onset hypoesthesia in the perineal region, worsening balance, ambulatory dysfunction. When he thinks about it, he and his daughter note that this has kind of been going on for several months, but it has gotten worse acutely or subacutely in the last couple days to weeks. Otherwise, his history is sort of unremarkable. There's nothing super special there. His physical exam, he had decreased sensation in both lower extremities, the right greater than the left. He also had weakness in his right iliopsoas and EHL. Otherwise, his strength was full in his lower extremities. He had brisk reflexes bilaterally, but he did not have any clonus, and his toes were down going. His MRI and CT scan tell the story of what's going on. He has a hyperostotic type of sort of PLL variant that's causing him to have multiple discosteophyte complexes. He's ankylosed at several levels at T6, 7, 7, 8, and 8, 9. He has disc herniations causing significant canal compromise. And then at T11 at the bottom has an osteophyte posteriorly, as well as up the top at T3, 4.
So there are two main things that continue to frustrate me, just like osteoporosis. And Neil, I'll ask you for your comment there. This patient has a variant of OPLL, so a hyperostotic disease process. It's a mixture of classic OPLL, hypertrophic facets and ligamentum flavum calcification and dish. That's the first thing. So this was not recognized. This patient came to us as a having a thoracic disc herniation. Yes. Because it was MRI based only, there's no CT obtained. Secondly, yet again, despite having two medical professionals in his own family, this very nice, hardworking man had developed profound myelopathy. Yes. And again, this was really astounding to everybody because they didn't know what was going on. The thought that this was a thoracic disease process did not occur to anybody. So the silent paralysis that myelopathy presents always confounds other medical professionals because they assume that if there's neural compromise, there's pain. Any thoughts on educating our medical colleagues more about myelopathy and obviously our radiology community about recognizing these kind of disease processes more, Neil?
Oh, I'm plagued by this because the community is even further down the learning scale than your positions in the tertiary care centers. You get these cases presented to you that are clearly well down the disease pathway, and they just haven't been worked up. And for whatever reason, perhaps it is that our colleagues, our referring colleagues, are so overworked in our present health system that they just don't have bandwidth to develop a sensitivity and an awareness. So it is most fortunate that as you graduate fellows and get them into the community, that at least improves the opportunity for trickle-down education, but it's very difficult to get direct education to our colleagues. They just don't have bandwidth.
So one thing that's a personal plea to me, I'm so grateful that you're with us this morning, is could we try to work on a thoracic myelopathy registry? Could we work on a DISH registry or hyperostotic disease registry? Because I think this is an international problem, and it amazes me at conferences how even spine surgery colleagues of ours, and I'm standing on a bandwagon here, but how they're ignorant about this. And I can assure you, maybe you can share your experiences at the University of Maryland with one of our leading institutions in the country, in the East Coast, certainly, how many surgeons would try to whittle away on the anterior column here. Nathan, how was it at the University of Maryland?
A lot of people would have tried to go after the anterior column. And I'd echo what you just said, that a lot of times people come from the community who'd had a 2-level T-lift because someone interprets something as being a radiculopathy that clearly isn't. They're not walking. They're like, oh, well, this must be the problem. They've got a small disc herniation, something like that. They come in with this MRI and say, well, here's the problem. And yeah, a lot of people would. I think that in general, for this multi-level thoracic disease, I think we would have tried to decompress the posterior column only and would have used ultrasound intraoperatively to look at the spinal cord. Is it free floating? Is it pulsatile? If it is, then I think that we would probably leave the anterior column alone at that point, and say, well, we have it decompressed. Let's see how you do. It's a much safer operation, obviously, and already compromised spinal cord. This patient essentially has an incomplete spinal cord injury at this point, to simply decompress everything and see how he does with time. As long as he's fused, the hyperostosis should not continue, versus if you were to simply decompress that would likely result in kind of not the optimum outcome.
And I know this is a bone of contention between neurosurgeons and orthopedic surgeons. Is there a number of levels that you can do a thoracic laminectomy on with impunity, or is it more a latitude, meaning how much facet joints you decompress?
I think that our approach, having done maybe a couple of cases, the most prominent one I remember is a patient that had epidural lipomatosis that was a chronic steroid use patient that extended from T3 down to about T11. We decompressed that alone. He had no deformity. He was otherwise doing well. So we decompressed it without instrumenting and he did fine. That being said, is that the typical? Probably not if someone has any evidence of instability, but if you leave the facet joints intact and you've got the rib cage reinforcing that area, it's a pretty, it's not a super mobile area of the spine. I think that you can probably leave that alone, assuming that they don't have a process like this going on or some other reason that you might be concerned that there could be additional instability.
So still a subject of much contention.
Yeah, I'm sure a lot of people would have used that.
This is a clinical case that shows bone healing is not a problem. For whatever endogenous process, probably an endocrine process with inflammation is going on in these patients, they form bone. This needs to be harvested and harnessed by industry. Show us what we did, and maybe Amir can tell us what he thinks, whether we did too much or too little.
Sounds good. So we did a T3 to T11 laminectomy infusion, decompression just posteriorly for his myelopathy. Surgery had no complications. He was in the ICU for 2 days just because of some issues with hypotension. He had been on pressors briefly in the OR. And then he was home before the sixth postoperative day, walking, doing great. And here are his postoperative images. This is actually a chest x-ray for the x-ray that we have there. We didn't have a standing x-ray yet for him, but you can see well decompressed throughout, screws T3 down to T11, everything really opened up wide posteriorly. We're able to resect part of the facet joint as well because we're instrumenting him so we can get a very wide decompression, which was sort of our intent. And we did not attempt to go after the ossified disc herniations the obvious concerns of, is this stuck to the cord? Is this really going to change his outcome? Are we helping him with this? And obviously in his case, he's done very well. He's very happy.
So we mapped the patient out. We did cervical and lumbar imaging also. We did CT,
yes.
MRI, and everybody. Amir, do you think, if you can talk right now, do you think that this is too much? And how much can we kind of correct the kyphosis by undercontouring the rods and aggressively resecting the facet joints? In other words, doing like Smith-Peterson type facetectomies at the key levels. So what do you think of this approach? How high?
Can you repeat the question? My feed kind of broke up for a second.
Okay, so how high, how low should we go? And can we correct through kypho correction by under-contouring rods and doing Smith-Peterson type aggressive facetectomies? In your experience, can we indirectly decompress the cord by straightening out the bend of the spine?
In these kind of hyperostotic cases, I do not try to do any correction. I worry about creating more fractures.
You're breaking up right now. Rod, are you on microphone? What do you think? Can we correct hyperkyphosis in these patients? We did it here.
I think on these cases, it's that's a great question. I think it depends on. It looks like there's some anterior osteophytes. I mean, looks like it's a pretty solid fusion mass that's there.
We actually did facetectomies. We actually compressed them posteriorly. That actually.
But I think if you go high enough, I mean, I do believe in the Charlie Kuntz model where, I think if you go up high enough, the cord actually does come back. What's interesting to me is, do you think they had vasoplegia post-op?
Yeah. We actually, very well put. We have a paper and peer review right now on vasoplegia. We all thought this is real, a sympathectomy effect or whatever, because he was we didn't lose much blood, right?
No, it was about 300 and not even 300 cc.
And
we were very meticulous about that.
He was done under elevated MAPs and steroids and nonetheless, had significant hypotension afterwards, which was very frustrating and caused an ICU stay because we obviously wanted to not have his blood pressures bottom out, but he did very well neurologically. He had an almost immediate recovery of very minimally supported ambulatory function. So thanks, Nathan. Let's switch to Dr. Cook. Great work on the presentations. And Amir, sorry, I didn't mean to cut you off. Your feed was breaking off from our end also. So any other comments, please let us know.
No, go ahead.
Thank you. So Jared, get yourself plugged in. Ben's helping. Maybe in the future we can put these onto the central computer, Jared.
We did. I did a quick edit.
You did a quick edit. Okay.
I really wanted to put something in.
So Dr. Tariq Sohail, our good friend, is asking, how can we prevent progression of OPLL? Amir, can you give us a brief discussion? I know you've done some work on this. Amir?
Sorry, I think we're having a bad feed on both directions. What was the question?
So Dr. Sohail, Tariq Sohail is asking, how can we prevent progression of OPLL?
So, I think this is something that, again, I think that we have not fleshed out in the literature as well. But, the kind of my general idea of how this works is that the bone is formed because the body is trying to stabilize itself. And so if we are able to do a fusion in those settings, it usually arrests the hypertrophic kind of bone formation. So, I think that the controversy is around patients with OPLL in, cervical laminoplasty. Is that sufficient to just make more room and not stabilize those patients? Are they going to form more bone anteriorly? But if you are able to stabilize it, you can use that kind of biology, and it usually forms a nice fusion and then stops progressing.
And one other comment, maybe Dr. Özgün can take this question. Dr. Cumhur Killinger from Turkey is asking us, he agrees with the procedure and the concept of indirect decompression posterior fusion. He feels we use too many screws in this hyperostotic disease. What are your thoughts on this? Did we use too much hardware?
No, I mean, I think if you do, based on the amount of decompression that you need to do, I think you have to do a fusion.
So for us, we actually discussed this in surgery. We can probably cut the screw number in half. The main thing for us is that we actually did full facetectomies in this patient in the critical mid-thoracic spine, the watershed area. And so intuitively, I wanted to make sure that we had optimum fixation everywhere. We did the screws prior to the decompression. We then did a laminotomy on both sides and elevated the lamina. before we lifted it off to let the cord re-equilibrate perfusion-wise. We shot an intraoperative CT scan. But given the radicalness of the facetectomies, I was very interested in making sure that we had screws at every level. Non-union is not a big factor, and this patient was pretty osteodense. So Chumur, I totally agree with the basic principle. You could probably save hardware, but here I felt this was medically necessary. And again, Tariq, your question of instrumentation and instability in the thoracic spine, this is a big question. For us, these hyperostotic diseases are an inflammatory process that is propagated as long as there's any form of tension on the PLL. And as we saw, Amir Abdul-Jabbar just mentioned that as long as there's motion, we see it with laminoplasties now in OPLL, there will be more bone overgrowth. So stopping that as good as we can with a fusion seems to be helpful. Dr. Cook, you're up next.
All right, thanks. I'm Jared Cook. I'm an orthopedic spine fellow, trained in Las Cruces, New Mexico. So the case that I'm presenting, say, 88-year-old male, presented with low back pain, bilateral lower extremity weakness. This had been going on for a few months from the patient's report. And only recently he lost the ability to ambulate completely, because of that pain and weakness. Denied bowel and bladder dysfunction. The only past medical history was SIADH in 2018, chronic hyponatremia. Did not have any history of malignancy. For his physical exam, so he did have some weakness on isolation testing, unable to to ambulate with this, some decreased reflexes, and then his imaging showed this lesion at L4, which encompassed the entire vertebral body, and then there was, I hope you can see the cursor, invasion into L5 and canal compromise, which you can see on that axial. And so there was also some extension proximally and distally at the L3 and L5 levels. So
1 second, Dr. Schonert, are you still on? Neil?
I am, Jens, but I can't see I can't see the imaging.
I'll ask you a general question. How much has the age demographic in your years of working with registries shifted? You were the state system. How much more are we confronted with spine surgeries and octa and nonagenarians in your time of observation?
It's breathtaking, and our generation, Jens, will actually carry this into triple digits. People will be surviving into the 90s, 100s, 105. They'll be functional. They'll have expectations. So the silver tsunami is, in fact, going to arrive on our beach very, very soon.
So this is another thing we've seen out of, just like what Dr. Schonert said in the publications. I urge everybody in their countries and their societies and communities to look at how age changes are happening, because we have to really come up with a better triage plan. Number 88, when I was a young attending in the early 90s, we would have probably said absolutely no surgery. This man is totally with it. He has hearing aids. He lives in an assisted facility, but his mental faculties are completely intact. And he basically, when asked, what are we going to do? You have a newly diagnosed malignancy. You've done all your healthcare throughout your life, and now there's some malignancy. We don't know what it is, but you acutely can't walk anymore. Do you want to have palliative care? Do you want to try radiation? Did you put the CT up also?
It's next.
Okay. He basically said, bring it on. And we strongly suspected it was prostate cancer. It's a mixed lytic and blastic lesion. He also has, again, DISH. He has a spontaneously fused spine on the top. It's actually more ankylosing spondylitis. I correct myself here. But he has a non-union, more or less, at the lumbar level. So they've maintained mobility. They've developed a severe stenosis at several levels. So we have a mixed lytic disease that came out of that L4 body that's ankylosed to L5. Do we do surgery or not? And what do we do with that partly eroded vertebra where this large metastatic mass that the MRI showed has caused? Rod, your thoughts in terms of decision-making, surgery or not? Who should get to make that decision? And what should we do, especially in light of, we don't want to do too much surgery if it goes there. What do we do with that eroded L4 vertebra?
Boy, this is a tough case. I think shared decision-making, which is something that our service employs, is warranted here. And I think at least a laminectomy, wide laminectomy at that one level. I think, did it go up to L3? It was hard to tell.
Yeah, the lesion went
Yeah.
L3. So the epidural mass ventrally went L3 to L5.
Yeah.
You'd have to do a pretty wide decompression to get around. A separation surgery, a la Larry Rines and Mark Bilski, would necessitate a destabilization. And then you have this about 50% eroded L4 vertebra to deal with. And this has large holes in it.
I mean, I think you can easily do, and I've done this before, you can do, put in some fixation, take out the facet joints, and if you need to, you can augment it. A lot of the companies now have fenestrated screws. But I would probably do an L2 to at least S1 laminectomy, go wide, and use fenestrated screws for fixation.
So Dr. Chumwar Killinger, I appreciate your comment. He suggested decompression and vertebroplasty. Why don't you show us what we did, Jared? And that's a very legitimate option. The patient has very poor bone stock. His Hounsfield units were, do you remember?
17.
17, so
17.
miserable. A normal minimum range is 110.
Now there are some other things from the workup. I mean, he also has a T6, a C7 lesion. He had a large prostatic lesion, adrenal lesion, and 2 brain mets. And yes, this guy literally said, "Bring it on." So, and then I added the SIN score for completeness sake. So I got him at 11. So. For intermediate. So what we ended up doing when L1 to the pelvis with posterior fusion, cement augmentation, and laminectomies L2 to L4, where we had that epidural extension, and partial corpectomy at L4. So we didn't use fenestrated screws, but we did do cement augmentation, with our top 2 screws, and then there was really no integrity to that L5. The extension went into the pedicles. There really was no real pedicle to speak of. Debulked the tumor, really separated it from the dura, and then used cement augmentation to fill the void, and then a quad rod construct, which we can see on our scout films from our post-op CT.
So pretty big surgery. How did the patient do so far?
So the patient is doing really well. It's been, one night in the ICU, mostly just because of the time that we got out of surgery. And then now the strength is coming back rapidly. It's looking good for him as far as, quality of life and everything goes. And all of this was done taking into account that if this is prostate cancer with brain mets, we're expecting about 4.5 months. And even with, even confronted with that, the patient wanted to, undergo this, try to regain the ability to walk for those last months. And so I think he's heading in that direction.
We had a very frank discussion with him before. He had 2 wonderful daughters who are his durable power of attorney. We did share decision-making, exactly what Dr. Skuyan said. We were a little bit pressed for time because he had acutely deteriorated. So then we had to move forward fast. Every service line came together within about 6 hours. Was impressive, but so far he's done very well. So for Dr. Moore later, we sometimes just put PMMA in. There's a barrier against tumor disease. It provides a nice sealant. The matter of screw augmentation is one that I'll ask you about later, maybe in your presentation. We do like, and we have seen value in these very hypodense patients to put an augmenting material into the screw tracks. And that's been biomechanically helpful. I'd be curious to see whether this can be reproduced with a implantable bone, which would be much preferable towards having a methyl methacrylate injected into the spine. Any other insights for you, Jared?
Insights on procedure decision making. No, I think we touched on all the important things. Make sure that we have as much structural integrity as we can get. Try to get the person the function that they the function that they're trying to get. Knowing kind of what they're in for rehab wise, and they're going to be rehabbing for probably the duration of their of their life. But if that's better than what they came in with, then that works.
I appreciate, so let's get Jerry on. Thank you, Jared. We have time for one more case before our guest speaker Dr. Mark Moore will speak. Chumar, I totally agree with you. Decompression vertebroplasty in older patients with oncologic disease sometimes can help. We felt here that the amount of the MRI detail that you were shown was not sufficient. We wanted to rely on radiation on him also. We wanted to do a true separation surgery. We felt we were clearly destabilizing the spine by having to go posterolaterally to get the anterior disease out. And for us, the placement of additional screws and rods was less invasive, but we have clearly changed more and more into just doing decompressions and vertebral augmentations and a very minimum posterior stabilization. So I agree that this is a shifting trend, and less might be more under certain circumstances. Dr. Robinson is going to close out our case presentations this morning. Good morning, Jerry.
Good morning. Thank you, everybody. My name is Jerry Robinson. I'm an ortho spine fellow here at Swedish, and I'm from Akron, Ohio. And today's patient, 40-year-old male with Down syndrome and has nonverbal developmental delay, is presenting with low back pain. Mom says that he fell in the driveway from a 6-foot-high structure about 9 months ago and has since then become less functional. They sought no medical attention at the time because the patient remobilized and seemed to have no injuries, but has had a slow downward decline ever since. He now ambulates by wheelchair and presents with persistent low back pain, and has a pitched forward appearance, according to mom. And he does not have any associated numbness, tingling, saddle anesthesia, or loss of bowel or bladder function. He had obtained outside hospital x-rays and diagnosed with a possible pathologic fracture at L4, but a biopsy at that time did not reveal any neoplasm, just fibrotic bone. Here you can see his exam, 3s, but difficult because of the patient's mental status and normal appearing reflexes. Here you can see this kyphotic collapse focally at L4 with the collapsed vertebral body. And like I said earlier, there was a biopsy that proved this was not neoplastic at the time. Here's some representative cuts from the CT scan. You can see air in there, likely representing an old fracture that has gone on to AVN or osteonecrosis with dissolving and bone void there. Here you can see the representative MRI cuts.
Jerry, can you go back?
Yes.
So Dr. Moore, for later for your talk, this is a clear case, we just lost the image here, where we would love to have a less invasive delivery modality so we can fill a large cavity like this with bone. This is an untreated burst fracture, obviously with an underlying syndromic disease process. The patient is independently or was independently ambulatory, but we would love to have a viable, good bone structure as long as we can provide stability. So maybe Jerry, go ahead. We have only 6 minutes left here.
Yep. And so the plan at this time was for 2-stage procedure with the posterior spinal fusion, quad rods, decompression, and then a lateral corpectomy afterwards for the bone void. So here you can see our post-surgical view with the quad rods and that extra screw at the burst level for added construct stability. And then here you can see like the scout image. We don't have a great AP from how the patient was able to lay, but here's some representative cuts. I can kind of scroll through that just briefly if anybody wants that. I have it for completeness sake, but patient's doing very well, now sitting without much pain. And up walking day 1 in the ICU, and mostly ICU just because of blood pressure issues from his normal, like kind of autonomic instability that he has at baseline, but doing well. And mom was very happy that he was up walking around.
So this is an unusual case, middle-aged trisomy 21 patient, Down syndrome patient, no craniocervical instability, no other major joint anomalies. A very clearly untreated traumatic burst fracture that was just missed and no fault by anybody. And now we had a significant problem with reconstruction. We did a very invasive surgery. Rod, you did this very beautiful XLIF. We planned this case together and we met with the family beforehand. So share with us how these cages have changed anterior column reconstruction, and what do you use for bone graft to kind of make sure that you have a viable biologic anterior column, not just this beautiful large titanium cage, no metallusion.
Well, it's interesting. So these cages provide a lot of structural support, and go back if you can, Jerry, you can see that, and it has a pretty significant amount of end plate coverage. Now, long-term, what I've seen, and we did this in this case, is the bone has a hard time growing through the cage. And if you follow these patients long-term, what's interesting is the bone actually grows around the cage. And so typically if it's a tumor, we'll try to take everything out and fill the cage with allograft and pack the sides. If it's a traumatic fracture, like something like this, we'll leave a shelf of bone on the other side and a screw. And I think that provides a very sound basis to perform a fusion. But interestingly, I have a lot of these cases where you get absolutely no bone growth across the implant because there's so much metal. But I think by just going in there and curetting, preparing the bed for a fusion, I think you get a solid fusion.
I also think post-operatively, the patient was able to immediately stand up, which was previously too painful to even tolerate in a nonverbal Down syndrome patient. So I think it speaks to just having that stability too of the spine, but that wasn't present previously there.
The other thing, what's interesting is you could see on the table, when we open the cage up, you could see the inner space open up, and you would think that you can't, but you can actually, those screws, because they're multi-axial, will windshield wiper up. And you can see we got probably another 15 degrees of correction.
So what was the lordosis pre and post-op?
I don't have it formally measured on here.
I have it measured. He was about 24 degrees kyphosis, and he went into about 60 degrees, measuring L1 to S1 lordosis. So
you can see that there.
And obviously, we're worried about the rostral junctional zone. We did not augment that area. We are trying to have him use a brace, but I'm not sure about that. Jim Hoover felt that or suggested that we might have gotten away with a pedicle subtraction osteotomy and a posterior shortening procedure because of lumbar kyphosis, and thus obviated the need for a cage. Amir, are you live? Amir? Neil, are you unmutable?
Yes.
What do you think? Could we have gotten away with a pedicle subtraction osteotomy? You're Rothman trained, you're UCSF trained, you have seen major deformity surgeries. You're old enough like me to know PSOs, lower lumbar spine, more forgiving than other areas. A PSO maybe alone versus a complex reconstruction surgery?
I'm in support of what you did here because you've got a patient who you have a communication deficit. You're going to have an extremely difficult time assessing the impact of what you do, other than observable things that the mother is tuned into. So subtle failure is going to be extremely difficult to discern. Catastrophic failure is the only thing you're going to be able to make judgments on. So the wiser approach is to be as thorough and complete as you can, because you're going to have a hard time, other than radiographic follow-up, giving surveillance on this. So I'm comfortable with what you've done, and I wouldn't do less.
Okay. Any other insights, Jerry? Yes.
Jens, can you hear me?
Yes, fire away. Amir, you're live.
Yeah, I was just going to mention that, with expandable cages, we've been able to get a lot of correction from just kind of transforaminal intradiscal work. And kind of 2 levels of intradiscal, we can get just as much as from PSO in many cases. And, depending on the amount of correction that you need, the rate of complications with PSOs is so high. I try to avoid them if I feel like it's possible. Sometimes with the plan to use an intradiscal technique, see how much I can get in terms of sagittal correction, and then switch and add in a PSO if I feel like it's warranted.
So great points. So for us, we want to make this bulletproof. Neil pointed out we needed to have the best possible controlled biomechanical environment and a marginally communicable patient. And again, he has an unusually intact social structure with a truly devoted mother, which played heavily in our decision-making process. So that was part of the process. So Jerry, thank you for the presentation. Thank you to our fellows, and thank you all for the commentaries. It's a great pleasure to ask our guest speaker, Dr. Mark Moore, to come up to the podium. He received his doctorate at the University of South Carolina. We have close ties to the state and appreciate that. He's done research at the University of Virginia, again, close ties, and at Harvard Medical School Children's Hospital in Boston. And he has developed implantable materials over quite a while. There's an amber alert going off right now. Sorry for that acoustic interference. And he's Global Senior Director of Scientific Affairs of LifeNet. And he was the chair of the American Association of Tissue Banks, and has, again, a unusually broad and in-depth knowledge of biomaterials and implantable devices and bone grafts. We'll have some difficult questions also, but with these cases, we want to show you some of our decision-making points, clinical needs, and also opportunities, i.e. the hyperostotic diseases, how we can enhance bone healing. Obviously, cost containment, being cost efficient, you saw it in some of the questions from our audience, which is global, is a very significant consideration. Without much further ado, Dr. Moore, thank you for being here today, and we're very interested in hearing your thoughts on how we can help bone healing.
All right, thank you, Dr. Chapman and Seattle Science Foundation for allowing me to speak today on the subject of advances in bone void fillers. I will be talking about two commercially available materials, one being Plyfix Prime DBM fibers, and the other one being a Vivigen cellular bone matrix. And for my disclosure, I do work at LifeNet Health, and we are the manufacturer of these two materials, and DePuy Synthes is the distribution partner for those materials. LifeNet Health is the world's largest, if you combine provision of allografts for implantation, organs for transplantation, and research cells and tissues. So when we're considering bone void filler options, here's a list here. What I'm going to be focusing on are human bone grafts, and this includes autografts, allografts, non-cellular, as well as cellular bone matrices, including stem cell, the theory of providing stem cells, and then the theory of providing bone cells directly in an implantable material. So factors that just to establish a baseline of what we consider in bone regeneration and bone healing, what you need for bone growth is you need an osteoconductive scaffold, you need something for bone to grow on, you need an osteoinductive signal, something to kickstart the process, and you need cells. So you need the osteogenic component because the cells are what actually grows a bone. So autografts, long considered a gold standard, have all three of those elements necessary for bone formation. Limitations with autograft can include limited supply, again, depending on the patient and the type of surgery, donor site morbidity, increased OR time, preparation variability, and what I mean there is how the graft is prepared, how long it's on the back table, where it's dried or not, and so on, and singular quality, which means that the graft is based on the patient's own bone. So certainly autografts have their place in procedures, absolutely, but there are some of these limitations. So what we find is a lot of clinicians will match the properties of the allograft, if you're choosing an allograft, with the clinical or patient complexity. And we've already had some discussion about that earlier. So starting in the lower left, if you have an basic allograft bone chip or cubes that are osteoconductive in nature, that may be very fine. If you're filling a cage with and you're doing a one-level ACDF on a young, healthy patient, using an basic osteoconductive allograft might be just fine. When you move up the scale, you can see I have two of demineralized bone matrices categories here. The lower one is the one with carrier. And the reason I put that lower is if you have a carrier mixed in with a DBM, that will dilute those native properties of the DBM, which would be the osteoconductive and osteoinductive properties of DBM. And then a little higher up the scale is a 100% DBM, which of course are osteoconductive and osteoinductive and not diluted with a carrier. And then the highest one here is a cellular bone allograft, which would be osteoconductive, inductive, and genic based on the presence of cells. And we'll explore that category quite a bit. So when you look at just traditional allografts, basic structural allografts could be used for interbody spacers, could be cortical struts and so on, or non-structural grafts, again, definitely have their place in the clinic. And these would be osteoconductive matrices. And then you move to the DBMs, taking advantage of the endogenous growth factors inherent within cortical bone. Those are trapped, so they're not bioavailable upon implant if you just implant cortical bone. However, if you demineralize that bone, mimicking the remodeling process and the microacidic environment the osteoclasts put out, that can remove some of the mineral content and expose those growth factors, again, making them bioavailable upon implant. So that's the basis for DBMs being osteoinductive. And it's important how those materials are demineralized. If you demineralize something too much, you can remove or denature the growth factors. If you demineralize too little, those growth factors remain trapped and, again, not bioavailable. The DBMs are classified in two different ways by FDA. If there's not a carrier present, they're classified as a human cell and tissue product and fall into that category. If a carrier is present, you can see some of the examples of the carriers here, then those materials need to go through the 510K pathway. And again, I'll point out that those carriers can potentially dilute the properties of the bone. So one of the materials I'll mention here is Plyfix Prime. It comes as a wafer, as you see on the left. It's a freeze-dried, 100% bone, moldable demineralized fibers after being rehydrated. And again, it's 100% bone, all cortical demineralized fibers. So as we prepared this, we want to make it moldable and versatile and mixing with materials, whatever materials the surgeon may want, autograft, blood, saline with antibiotics, whatever it might be. And the fibers, we specifically designed the fibers. And the best way to show you this here is the morphological image on the left, where you see those fibers have these micro hooks in them. So think of it like Teflon. So when it's rehydrated, that's what gives the moldable handling characteristics of this material. And then it's also a biohospitable matrix with cells being attached quickly and being able to spread also. And we've tried to control, or we have controlled the demineralization process. So we have a physiological level of growth factors such as BMP2 and BMP7, as you see here. And of course, we've done a lot of studies to show that this material does form new bone in vivo. So that's the DBM here. And
sterilization of bone graft with the recent severe cases of TB. There was a single donor who had TB, as you know, from a different manufacturer, not your company. And there were, I think, 105 patients contaminated with TB bone. Talk to us about bone graft sterilization and how much viability bone graft can have after you've either radiated them or washed them or chemically disinfected them. How much viability do we have left after we've disinfected bone?
If the graft is, well, like the graft I just showed you here, if that is, that sort of graft would have very low viability and a very low risk of potential contamination. And the reason is that those grafts, if it's a demineralized bone matrix that's sterilized as we do with terminal sterilization, if you consider that, there's often peroxides used in the processing of bone. There's acid used for demineralization. And then there's other cleaning processes and then terminal sterilization event. So the risk there of any sort of disease transmission it's essentially non-existent. And that's the history that we have with our material since we've introduced advanced cleaning technologies 25 years ago, over 7 million grafts without a single instance of disease transmission. And now you move to the now you move to the cellular grafts and the cellular graft category. So let me move ahead to where I was here. And so now the cellular grafts, to answer that question, due to the nature of them being cellular and viable, there's going to be less extreme processing. So inherently, you'd have to say that the risk of disease transmission would be higher with those grafts because they're not acid treated and terminally sterilized and so on. However, what happens with companies such as ours is we go through an extreme donor screening process. There's testing. There's various things that are done to ensure that there's not going to be a disease transmission. The viable graft that I'm going to talk about here, we process at risk. In other words, we process that tissue within, we start within 24 hours of death. And then we have to keep that tissue after it's been made and go through all of the donor screening information that we have, the medical history. We have an MD that reviews every single patient chart and tries to do what they can to minimize risk of disease transmission. And with a cellular graft, I'll be talking about Vivigen. We've had we estimate 200,000 grafts implanted to date without any concern about disease transmission. But it is, certainly is a subject to be aware of. So demineralized bone matrix, and we'll go through the Plyfix Prime again here. And so we're back here to this category. Again, we talked about the DBMs, the demineralized bone matrix, and now we'll move on to the cellular grafts. So the allogeneic cellular bone matrices, those have emerged as an alternative to autograft. It's donated human tissue processed to retain the same bone forming elements as autograft without the associated complications. So this graph here shows what I consider to be the first generation of allograft cellular matrices and the hypothesis of those. The idea was to provide in a bone grafting material mesenchymal stem cells that would in the body differentiate into lineage committed bone cells. And so when we started developing a cellular graft, we asked the question, well, could those mesenchymal cells differentiate into something else other than bone cells? And also, what about the several week lag time it takes for mesenchymal stem cells to convert into bone cells? So when we looked at this and saw how the cellular grafts that were available at that time, the hypothesis of them, we said, well, if the ultimate goal is to have bone cells in your surgical site to grow new bone, perhaps there's a new hypothesis that cells themselves can work. And so we asked this, can just transplanting bone cells, does that make sense? And so let's see, we seem to have another challenge with the yeah, okay, good deal. And can those bone cells by themselves work? So we did a literature search and we found two key studies. Both of these are essentially allograft transplantations, rodent to rodent, and both of them involve putting materials on a scaffold and seeing what happens at that point. So in the upper panels, what you see is when mesenchymal stem cells were put on a scaffold and transplanted, they go away within 30 days. The lower sets of panels are osteoblasts. So these are bone cells, and those cells survive, they persist, and they directly participate in the formation of mature bone. The other experiment was similar in a way where different materials are placed on a scaffold. Let me draw your attention to the second bar from the right. So those are osteoblasts put on a scaffold and transplanted. And what you see is more bone formation, more mineralization with the bone cells than the materials to the left of that, which would be either the scaffold with BMP on it, the scaffold with mesenchymal stem cells on it, or a scaffold with both of those. So these two experiments together demonstrate to us that it's certainly feasible to directly transplant bone cells. There was nothing magical about transplanting mesenchymal stem cells. So that's what we did. We went about producing this material, Vivigen, containing all those three components necessary for bone formation. We have cortical cancellous chips with live bone cells that we obtain from the ilia, from femoral head, from the talar head, and so on. And then from the long bone, we get cortical bone, and we make osteoinductive DBM, and we recombine it and then package it and again, put it in cryopreservation while we're doing all the donor screening and all the testing that needs to be done. So again, Vivigen, we focus totally on preserving lineage committed bone cells that are inherently present in bone and we're not concerned about the other cells. So what does that look like physically? Well, let me show you this histology here. And the two left panels, what you see is in-process bone preparation. And you see bony chips, and you also see the marrow and other blood elements. And then the right two panels are the Vivigen material that's been fully processed. So you see a much cleaner matrix. Now, when we stain in the upper two panels for mesenchymal stem cells, we see some level of stem cells in the in-process material. Those are gone in the final material, which is fine. We're not concerned about stem cells. And the lower two panels are staining for bone cells by the presence of osteocalcin. And you see osteocalcin staining in the marrow component and in the chips, the cortical cancellous chips. And after processing, you still see that staining. So that's indicative or suggestive that there may be bone cells in those chips. Well, when we take those cells and put them into a media, what we see are cells that are coming out and they're able to grow. So that indicates that indeed those chips have living bone cells. And when we stain those cells for osteocalcin, they test positive. And so that's an indication of the osteoblastic or bone-forming nature of those cells. And further, if we do a gene expression assay and look at the green bars here, which are the messenger RNA from the Vivigen-derived bone cells and donors, we see a robust expression of the three hallmark genes for osteoblasts, which are osteopontin, osteocalcin, and BMP2, again, further indicating that these indeed are osteoblasts that are in those bone cells. So these cells are genotypically acting like bone cells, and phenotypically, if you place them into an osteogenic media, and within as early as 7 days, we're getting a bony deposit, suggesting that, again, these cells can directly participate in bone formation. So Vivigen comes in a thin-walled plastic tube, and that is specifically designed in order to have a rapid thawing of this material, which is handy in the OR. We also know that a rapid thaw of cells are crucial for maintaining cell viability. And Vivigen, the two members of the Vivigen family until recently were Vivigen by itself. Both these have the same components in them. The only difference is the DBM. In the original Vivigen, the DBM was particulate, so it has kind of a wet sand feel to it. And the DBM in the Vivigen formable, or the fibers, like I talked about earlier, so has a much more moldable characteristic. And then the newest member of the family is using Vivigen and preloading it into a cannula. And that comes with a delivery device where that graft can be extruded into tight places. So Vivigen, being classified as a human cell and tissue product, can be used for homologous use in any particular bone void filling application. So let me go through real quickly 3 different clinical studies that have been published. And I'll just show you some of the highlights. This is a study from John Hall at down in Flagstaff. And Dr. Hall, this is a retrospective study, looked at 150 consecutive patients where he used Vivigen in lumbar fusion surgery. And his levels went from 1 up to 11, average of 4.1 levels. And he had an extremely high successful fusion rate. Now, this was at the termination visit. So in his practice, he sees the patients, he sees the patients again, he follows up with them, and then when he feels like they're good, he does a final X-ray and such. So, so the retrospective study, nearly everyone was considered fused at that point. Again, lumbar fusion surgery, and then a sub-analysis where he looked at where the preponderance of his patients were on the 4 and 5 levels, where he looked at either no tobacco use or current or former tobacco use. And all those patients exhibited fusion as measured by Lenke A or Lenke B. And on the previous slide, those are also a sum of the Lenke A and Lenke B being considered successful fusion. Here's another study which we performed. This is a large data study. So we harvested information out of the Premier database and found that they had 16,000 patients that had undergone lumbar fusion procedures. And this is all based on ICD codes. And about 6,600 had received Vivigen at the index procedure, the initial surgery, and about 9,600 had received Vivigen, Infuse, and then about 20% of each each of those had returned to that hospital system for rehospitalization for something. You could have been appendectomy or whatever it was that they came back into that hospital system over the next 12 months. One bit of information obtained from the ICD codes were charges. And what was found here was that there was a significantly fewer charges for the Vivigen patients. And you can see in the left two bars that the index, the initial hospitalization versus the infused patients, and then the follow-up hospitalization in that next 12 months, the same trend persisted. And we first wondered, well, could this be due to the fact that maybe infuse is being used on much more complex patients and it's more expensive? And what we found when we did a sub-analysis on the right, when we just looked at single level procedures, so it's apples to apples here, we still found a significant difference in costs and charges. And so why was this? It's probably a cluster of a lot of smaller factors, product costs. We know there's a difference there with the materials. Adjunct graft materials, Vivigen comes by itself. It's basically, think of it as an autograft off the shelf. And some of these other materials may be combined, infused may be combined with adjunct materials. And you also have the OR time that it takes to produce, to mix and such. And so that may be a difference. And then non-cost effective use. We found that some of the hospital systems tended to use infuse in a larger size than perhaps they needed to for that procedure. So that could have had something to do with it. And then the length of stay, we found that there was a significant, statistically significant difference in a lower length of stay with the Vivigen patients than the infused patients. So taking all those things together, this may have at least partially accounted for the lesser cost. And also in this study, when we did look at the follow-up hospitalizations in the next 12 months, we found that about 3.7% of the Vivigen patients had a subsequent lumbar fusion surgery, and approximately 4.6% of the infused patients had a subsequent lumbar fusion surgery. So certainly relatively equivalent in terms of clinical follow-up here between those two materials. This is the final study. I'll quickly talk about. This is from Hossein El-Ghafi at the Toledo Medical Center. So this is also a retrospective study. All cases were performed by Dr. El-Ghafi. There are 96 consecutive patients where he performed instrumented posterior lumbar fusion surgery with or without TLIF, and 72% of the patients had one or more comorbidities and or lifestyle risk factors that were significant. And his also with a Lenke A or B, he considered that 92% of those patients had successful fusion at his termination visit. And here you see some of the data. So his weren't the same number of levels as Dr. Hall's, but his patients went from 1 to 5 levels here. And you can see the level, again, what was considered Lenke A or Lenke B fusion with these cases at their termination visit using Vivigen as the bone void filler. And he had also had consistently successful fusion among higher risk patients. And you can see the comorbidities here. The lowest level of fusion was in the current tobacco users, which isn't much of a surprise here. He also found a statistically significant difference, a lessening of the ODI score, which are the 2 bars on the left, and then the VAS score, which are the 2 bars on the right, pre and post-operative using Vivigen. And all these studies and some of the other references I referred to here, I didn't list those individually in the slides, but those can all be found through the Vivigen compendium, digital compendium on our website. So what I've done here is I've talked in general about advanced bone void fillers, but really focused on these 2 materials, 100% DBM, Plyfix Prime, and then also 100% allograft Vivigen or Vivigen formable, and now the Vivigen MIS system. Again, also 100% bone with viable cells and DBM included as well. So what I hope is that giving you some information that may or may not, may come in handy as you're trying to match that allograft use with the clinical or patient complexity in your procedures. And with that, I want to thank you for, again, inviting me here today, and be happy to answer any questions.
Thank you, Dr. Moore. Great talk. Ben, can you turn on the microphone? It's not. No, it's not. Hello, hello. Now we're on. So, Dr. Moore, thank you for this great talk. Can you go back a slide again to the hierarchy? So, if I understand your one of your talk points before, I use Infuse, the medical product by a rivaling manufacturer, recombinant bone morphogenic protein. Are you telling me that I don't have to use that anymore? I use it in very select patients. I don't do minimally invasive surgery, but I do it in healing impaired patients. And for me, human beings can be justifiably differentiated into two categories, bone formers and bone non-formers. And the latter category can be quite recalcitrant. So for predictably healing impaired patients, I will use under off-label applications. The substance has worked actually quite well. So are you telling me based on these research proposals that you've, or these research publications that you've shown, that I don't have to use Infuse anymore?
Yeah, as a scientist, I can't tell you that, definitive that may not be a good option in some cases. Certainly it's a good option in some cases, but with Vivigen, what we find with all those properties that are there, what we're hearing is that doctors are switching from Infuse to Vivigen, and they're very, very happy with that switch. Can I tell you that there's not some patients where it might work better? I don't know enough about from patient to patient variability to say that, but the people have made that switch and they're very happy with it.
So this is obviously a very compelling point. Roughly percentage-wise, obviously not franc dollars because that's highly proprietary, but roughly percentage-wise, volume by volume unit, or effective volume unit, what percentage cost savings might we incur? I know you showed that one slide about hospital costs, but just now concentrating on the unit-to-unit cost, what percentage cost savings might we incur if we use a cellular product as opposed to a recombinant bone morphogenic protein?
Again, that's going to vary.
I just am asking for
it's less. As I've been around, kind of hearing conversations, I would, if I had to say about half. I mean, but it depends on the on the size that's being used, obviously, because some people can use an Infuse, a recombinant product, and combine it with something else. They may use a small kit and then throw the sponge away and combine it with Kinsella's chips or whatever they might do there. So you have those costs to consider as well. And some people will take something like an Infuse and again combine it with say, well, let's have some PRP in here as well. So it's hard to compare those apples to apples, but it's definitely less.
Full disclosure, I sit on the osteobiologics committee of the Providence Health System. So we always struggle when we try to compare apples to apples. Right. And we're very worried that we're not actually comparing even apples to a fellow vegetable, but rocks or whatever, something other than that. So this is really a difficult subject for us. It would help greatly to have not just outcome studies, but also quantifiable cost comparisons.
Yeah. And we actually have those. I don't have those here. I know our team has those. So those sorts of comparative costs. And then you also get into that with that scale with the, you mentioned with the complexity, you get into that where when do you need that? So if you have something further down the scale, like a simple chips or even this Plyfix Prime DBM fibers, which would be less expensive than a cellular bone matrix, and it's deciding which patients that's sufficient for, and that's a tough thing.
Now, the key thing is, again, the osteogenicity of the cellular bone allograft. I have heard from other basic scientists that the actual cell viability in the products that we take out of our fridge, right, it's refrigerated, and open up in the field is very heavily debated and has not been truly proven. So are these just skeptics? Or you mentioned that you had kind of data that shows that these cells survive, that you have a certain number of cells that are alive and that survive in their host. So how do we know that we actually have living cells when we open the package, thaw it properly, and put it into the patient? And how much do we know that these cells actually survive in a hostile environment over the next I think 7 days is a critical first laydown phase.
Right. Right. Well, we definitely know from benchtop studies that after preparation, cryopreservation, thawing, sitting on the back table up to 2 hours, which is what our product's approved for, and that the cells retain the viability during that phase. What happens when you put it in a patient, and that's harder to determine. And it's just like when you transplant an autograft, and how long do those cells persist after you transplant them? So that's hard to know. Some of the data I showed you here from the animal models indicate that those cells would stick around for a while. So that's it's hard to tell. You're putting things in there. You have the DBM, you have the cells, you have growth factors that might be with the DBM. So what's actually leading to the fusion? It's probably a combination of those.
So then one other thing, and I ask critical questions. I apologize for that, but I'm infamous for that. In Global Spine Journal, 2019, and again, full disclosure, I am one of the co-editors in chief of that. A number of international thought leaders, including Jeff Wong from USC. First author was Patrick C. Published a systematic reviews, again, 2019, but they included articles through 2018, and they could not identify any advantages of cellular bone matrices. They had a large intake number, and again, you showed some more recent studies, but I think they had some pretty good methodologists guiding them, and a pretty noteworthy panel. So I don't know, were they familiar with that Patrick C. study? What are your thoughts on that? Are they just out of date? Does that need to be updated with more recent publications? They couldn't find any difference to regular allografts or a competitive advantage.
Yeah, one of the challenges there is an overall challenge with comparing materials, whatever the material is. So you have to have someone that's going to support the study. If it's a competitive thing, you have to have someone who's going to sponsor that, and it can be a challenge. I do think if that were updated, it'd be more favorable towards the cellular allografts with new information that has come out. One thing to keep in mind is that the cellular grafts, being a classified human cell and tissue product, they are not required to go through a series of IDE studies, for example, like an infuse. So, if the companies are not required to do that, there's automatically going to be less studies probably that are being performed. They're not required out the gate. So then you're getting the studies after the materials have been commercially available. And that's what we're starting to see roll out now.
Great point. So Dr. Schonert, you have another question. Thanks for staying on. I know you have an OR starting. Dr. Schonert, can you speak?
Yeah, I wanted to comment. This is really a great talk. You did two things. You talked about a product and you talked about a device. The device is really thoughtful. And the product, I have concerns, and only because your comments on who got this product, there's a great deal of heterogeneity in the patient characteristics who got the product. There's a great deal of heterogeneity in the process of care. Even though this was two sites, two surgeons, their isolated practices, not a global application of the product across all who would have access to it. And you had a lot of heterogeneity in the disease that was being treated. Now, both Jens and I know from publications that we've participated in that the predictive capability of outcomes for spine surgery are influenced by patient characteristics more than anything else. So for the product to really get traction, I would imagine you would have to identify those cases that are revision and those that are not, those that have smoking or opioids and those that do not, those that have Medicaid or labor and industries and those that do not, in order to be able to drill down in differences of performance between this product and your other marketplace comparators. So congratulations on the product itself. Congratulations on the device. And I think you're off to a good start. The next level is getting the heterogeneity and the surveillance that'll solidify the outcomes that you've shown so far. Thank you.
Thank you very much.
Any comment on that or?
No, I agree. And I wish there was an algorithm of, and you had these great case presentations earlier, and I know the demographic and such were limited here in terms of what you can present. But if you have every patient that's this old and this comorbidity, and you add up 20 things and plug it into an algorithm and tell you exactly which allograft to use, that would be fantastic. But that is very difficult, and that really is the challenge, especially as these materials, these bone void filling materials evolve. And then all of a sudden you have something new, and now you have to compare them to others. So it's definitely a challenge, but I agree. And I appreciate the comment. I think we are off to a great start.
Yeah. We have to come to a close, but again, full disclosure, third disclosure on a row. One of those articles was a former fellow of mine, Hossein El Ghafi, great guy. But again, methodologically, I'd have to say, this is interesting, single surgeon series. He's a very honest investigator. There's not a shred of doubt about that. But again, for me, the devil's in the detail, just like what Dr. Schonert said. There are clear, and we've published on that even in JAMA together, there are clear risk factor categories, the healers, the non-healers, and that's not necessarily a flow. There are two camps almost. The non-healers, we can better and better identify and categories of severity. So stratifying this data, not just by smokers, but by other factors would be very helpful. Okay. And again, having independent reviewers, we can talk offline later about some models that we could envision in that regard. For us, thank you, Dr. Schonert. He has to scrub in now. Always enjoy your commentaries and input, much valued. But for us, again, who also are kind of asked by administrators to advise on how do we use our financial resources, having comparable cost data that is direct as much as possible, condensed down, would be eminently helpful to argue in favor of these premium priced bone graft products.
Okay.
Thank you. Yeah. Thank you for coming. Much appreciated. Thank you, Leifman. Thank you, Dr. Moore.
Thank you.
Thank you all for joining us. And don't forget, next Friday, Saturday, so this Friday, Saturday's arthroplasty course, you can see how you can claim your CME credits. And I want to thank our SSF crew for running us through this meeting and handling the various technological challenges, however and wherever they rise up. And again, we can put up the registration slide for the arthroplasty course maybe. In closing, thank you.